All right, just to finish the last little part of this, there is a complication related to hypothyroidism called myxedema. It comes from an acute illness sometimes. You get very decreased cellular energy and buildup of metabolites, and the patient actually builds up mucoprotein in their interstitial space. And you see this in terms of this buildup of proteins and swelling around the periorbital area of the face, in the hands and feet. They will also usually have low sodium levels or be hyponatremic. They may have low blood sugar, low body temperature, and altered levels of consciousness. And myxedema is often can be referred to as myxedema coma. But this to see the kind of physical attributes that you may see. This is kind of some pictures before and after treatment where they've had this type of edema, and you can see the difference in the gentleman's face and around his eyes and his neck, and then afterwards how much that's reduced. And then even in the patient's legs over here to the left, the one on the far left is got a lot of the edema and swelling, whereas the one on the right has had treatment, and even though it doesn't look that great, it's a lot less edematous. These are some of the common features. They'll have a very dull skin tone, very puffy. Their hair will be very coarse but have a lot of missing places in terms of sparseness of hair. They'll have periorbital edema around their eyes, and then they often have a very prominent protruding tongue. It's considered kind of a crisis that needs emergency care when somebody goes into this kind of coma with hypothyroidism because of all the issues that you see. They're hypotensive, they have hypoglycemia, they're hypothermic, they're in a coma. So obviously maintaining an airway is a very key thing, and if you think about that tongue protrusion, you worry that some of this edema around the face and neck is going to create an airway issue. You want to constantly assess level of consciousness. You want to get an IV going in this person. Typically with normal saline, they're going to probably need a bolus related to the hypotension. They usually receive a levothyroxine IV to kind of bring up the thyroid levels, as well as glucose IV to bring up the hypoglycemia. So this is a slide that kind of shows the gamut from the two severe ends of hyper and hypothyroid conditions. Now I want to talk a little bit about the parathyroid glands. Their role is to really regulate the blood level of calcium. And earlier, I was saying how that the parathyroid glands and their location, you can see that very carefully on this slide. They're kind of embedded in the medial sides of the thyroid gland. So you can imagine when someone has thyroid surgery that there is an opportunity for a bad outcome in terms of, if you go to remove something and you mess up the thyroid gland in that area, or if you have to take out the whole thing, you're going to that's going to affect the parathyroid glands as well. Parathyroid glands secrete parathyroid hormone. And the function of it is to act on the bone, kidneys, and indirectly on the GI tract. And its whole function is to keep calcium in the bloodstream. And it does this in a variety of ways, as you can kind of see here from a patho standpoint. It literally will stimulate calcium to come out of the bones and into the bloodstream. And so what do you know from our osteoporosis lecture, these patients that have hyperparathyroidism are probably going to have some pretty significant potential for bone abnormalities. And then you have parathyroid hormone also increases the calcium reabsorption in the kidney. So it's kind of keeping it in the system and not letting you excrete it out. And it also stimulates the vitamin D to be converted to an active form in the kidney, and that makes it much more able for your body to absorb calcium through the GI tract. This is just a kind of a picture to see how the thyroid and the parathyroid work together when it comes to calcium. And I would really try to get this in your mind, how this works, because when you're trying to, figure out why your patient has, thyroid problems or calcium levels that are out of whack, this is somewhat helpful. I like to start over here on number 1, where the calcium, say your calcium level begins to rise to a higher than normal level, your thyroid gland first recognizes that and releases calcitonin. And calcitonin, it causes the uptake of calcium back into the bones, and it causes calcium levels to fall. And so when the calcium levels fall too low, then the parathyroid gland is stimulated to release parathyroid hormone and do what we just talked about and bring the calcium levels in the blood back up. So in this way, this is kind of like a cyclical hormonal response that is normal in patients. So if you think someone has got, problems with either one of these glands, you want to kind of think about how could the problem with the thyroid gland or the parathyroid gland cause calcium levels to be adjusted. When we talk about hyperparathyroidism, please refer to table 63.3 because it gives you a lot more detail than even this related to some of the things that go on with this. But primary hyperparathyroidism, meaning that there's an issue with the parathyroid gland itself, 90% of the cases of this come from a single parathyroid adenoma that's usually benign, and it's a small growth that is usually in or around the parathyroid gland. You can also have what's called congenital hyperplasia, meaning just growth of tissue around the parathyroid gland that is because of some genetic abnormality. And as you imagine, you can also have neck trauma, including having had a thyroid surgery that, stimulated, again, parathyroid hormone because of how close it was in proximity to that. Secondarily, and we don't get into a lot with chronic renal failure, but chronic renal failure causes hypocalcemia and hyperphosphatemia. And because of that, patients that have chronic renal failure often will have hyperparathyroidism because it is trying to react to the low levels of calcium that is in the bloodstream and starts jacking up and producing more parathyroid hormone in an effort to try to increase the serum calcium. And the effects on the bones and stones are important to remember. When someone has hyperparathyroidism, because of this big release of calcium from the bone, it makes their bones much more likely to have fractures. In relationship to what we're going to talk about on Thursday, patients have high serum calcium levels. The calcium can get where it gets stuck together, creating kidney stones, and that causes problems in the kidneys. Signs and symptoms that you usually see with this is weakness. You usually see a decrease in reflexes. You may see constipation as well as fatigue. These are just some of the risk factors to know. Of course, this is also more common in women than in men. Patients that have this usually get it in their 40s and 50s. They have a history of head and neck radiation that we talked about when we talked about throat cancers. Can also make this a risk factor. And then patients that take lithium for a long period of time can also develop this too. This is a great slide to try to commit to memory. What would you expect in terms of these levels being high or low, depending on whether you're hyper or hypoparathyroidism. And just make sure that you really try to get these committed down to memory, because it really helps you better understand what's going on with your patient when you start looking at, calcium and phosphorus and magnesium levels, and how some of their hormones are affecting this. The treatment for hyperparathyroidism, you can do a parathyroidectomy to just remove the affected parathyroid gland. It's not uncommon for you to see calcium levels very high, calcium spilling over into the urine, of course reduced bone density, and sometimes patients also have what's called autotransplantation, where they take a portion of the parathyroid and literally out and transplant it in another part of the body to grow in a different location. Patients with this, you want to have them try to keep their activity up because of the impact, to keeping their bones in better condition. You want them to avoid taking vitamin A and D and calcium-based over-the-counter medications because of the other problems. They're often put on calcimimetrics. One of those drugs is called Sensipar, that reduces parathyroid hormone production and release, which is great, and you need that. You also might remember that biphosphates, or a drug like Fosamax, was given for osteopenia or osteoporosis to inhibit bone reabsorption, and that is also very effective with this disease. The patients usually get IV phosphate or calcitonin to decrease the calcium rapidly. And then they also are a lot of times put on diuretics like furosemide or Uritrol, and this kind of pushes the kidneys to excrete more calcium out through the kidneys. And then hypoparathyroidism is very rare. Sometimes this happens because when you're doing a total thyroidectomy, you remove all the parathyroid tissue, and then you just really have no parathyroid hormone really being released. Hypomagnesemia, or low magnesium in the blood, can also be associated with malabsorption conditions, with alcoholics and renal disease, and it will actually secondarily kind of cause hypoparathyroidism. For your nursing care, you're going to really watch for signs of low calcium, because obviously if they don't have parathyroid hormone, jacking up their calcium, they have the opposite problem of very low calcium. They can get what's called tetany, where they have tingling, numbness around the mouth, feet, hands, even with mild to moderate hypocalcemia. And with severe hypocalcemia, they can get severe seizures and spasms. So you're really kind of treating them potentially for potential seizures as well. They end up, in terms of interventions, on IV calcium gluconate or calcium chloride to kind of treat the tetany. Obviously, you want to put these patients on a heart monitor their heart, because calcium is an electrical conductor for the heart rhythm, and with low calcium levels, you may have some serious heart arrhythmias going on. These patients are going to always need to be on long-term calcium therapy, and as we've talked about before, they need high-dose vitamin D supplementation so that they really absorb calcium both from their pill and from their diets. With low calcium, of course, you have increased neuromuscular excitability, and you will see on their EKG what is called a prolonged QT interval that can really cause some serious problems with their heart. Thank you for listening.